Welcome to the virtual trauma meeting. The aim is to provide a friendly environment for open case-based discussions with the help of orthopaedic trainees and consultants to build upon orthopaedic knowledge and experience for undergraduates. Please could you present the case for us?
So the case is an 89-year-old lady who's had a left neck of femur fracture. She fell last night at home. She can't exactly remember how, but she said she felt a bit dizzy, and next thing she knew, she was on the floor. And she had a pendant alarm which she pressed, and she waited a few hours for the ambulance and was then brought in. She's got a background of Alzheimer's dementia, which is in its early stages, hypertension, and she's currently awaiting a colonoscopy. She lives alone. She's in the past refused carers and walks independently, but she furniture walks and has had multiple falls. She's independent with her activities of daily living. She has help from her family. In the department, she was alert, GCS 15. There were no other injuries. It was a closed injury, neurovascularly intact. Observations were stable, and an ECG was done because of the dizziness, and that was normal sinus rhythm. So she had a fascia iliaca block, and she's marked and consented.
John, you talked about the ECG, about the dizziness. So essentially, this lady's had an unexplained fall, what we often call a collapsed query cause. That's probably an expression that you've all heard. And that's not something that, as orthopedic surgeons, that we deal with on its own, but it's something that we have to recognise and start the investigations and engage the appropriate people, which in this case would probably be the orthogeriatricians. So an ECG was one of the things that's been organised, and then the orthogeriatricians would likely do a bit more. You also mentioned the colonoscopy. So my concern hearing that is going to be anemia. Is she anemic?
No, her hemoglobin's actually 132.
Okay, because I'm worried about her preoperative hemoglobin level, but that's good. That's good to know. Fine. Did you do an AMTS for her?
Yes, I did. It was 7 out of 10.
Okay, she's quite a high-functioning person with dementia.
Yeah.
All right. Okay, great.
For the benefit of everybody listening, an AMTS is an abbreviated mental test score. So there's a much longer mental test score, but the abbreviated one it's 10 questions to assess a patient's cognitive state.
And it's a mixture of basic questions about the patient, basic general knowledge questions, and then also a bit of dynamic, so short-term memory and attention. 8 out of 10 or above is normal, and 6 out of 10 or below is confused, and in the middle is borderline.
We do it on admission, don't we?
Yeah.
And when do we repeat it?
Then we repeat it every day post-operatively. Well, actually, we use a slightly different score now, which is a 4AT, but it's the same idea. And what we're doing is we're monitoring confusion because delirium is very common post-operatively in these patients. So they have a daily mental state test. And if there's evidence of delirium, we'll look for a source of the confusion.
The reason for doing it when they first come in is to get a baseline, because what we're trying to distinguish between is whether they have established dementia or whether they become delirious during their inpatient stay, because that's very important to distinguish between the two. One needs investigating, one does not.
What are we looking at?
On the left-hand side, you can see there's an extracapsular fracture to the femur.
Excellent. Okay, so there's a fracture of the neck of femur, the proximal femur. So has anybody seen someone come in with a broken hip, with a shortened externally rotated leg?
Yes, I have.
Good. We don't all lie, when we lie in bed, we don't lie there with shortened externally rotated legs. Why have they got that?
I thought the shortening would be to do with if the bones were moved to overlap each other, they might be shortened. You're probably going to compensate for, I don't know, pain or something, which might be why it changed direction.
Yep, absolutely right. So you can see this bit up here probably used to be down there, didn't it? And this whole femur has shortened up in that direction. Now the external rotation happens. So the muscle attachments you've got, your abductors are coming down here. So you've got gluteus medius and gluteus minimus all coming down here. And then you've got your main flexor coming down here onto the lesser trochanter. They're holding it in balance at the moment, aren't they? But if you lose the attachment, the pull of the muscles is going to pull them to a different position from where they've been, because the structure of the bone allows the muscles to be at a certain tension, a certain length, so they can actually act and do their job, whether it's an abductor or it's a flexor. And if you've got unopposed action of those muscles, then the abductors will actually cause it to externally rotate. And iliopsoas, it's still attached to that bit of bone there, so that will flex that up as well. And the abductors coming around here are causing the external rotation.
Just checking, it's the abductors which cause the external rotation.
Yes, you're correct.
And what did you say their attachment points were again?
So the abductors attach onto the greater trochanter, and iliopsoas attaches onto the lesser trochanter.
So if you've got an intracapsular fracture, do you get an externally rotated leg still? Because you've still got the fractures still cause the movement in the bones, so the muscles still pull differently.
Yes, you do tend to. It gets shortened up because of the fracture. You don't have that bone structure to hold it in place. And you get probably slightly less external rotation because it's not as displaced as an extracapsular one. But I suspect from how people hold it in pain, it's going to be fewer muscles in tension with external rotation. They'll just relax in that position. And so one of the things I think that's changed quite a lot in terms of their initial treatment is the fascioiliaca block, which John talked about, which now happens for all patients should happen in the emergency department, which is an early regional block to provide them some initial pain relief, which has actually become much more effective over the years, especially if it's done with ultrasound. Great. Now you've called it an extracapsular fracture. What makes you think that?
So the fracture line looks as if it's between the two trochanters.
Yep.
So below the neck, so shouldn't interrupt the blood supply.
Yeah. So that's the importance of the capsule, isn't it? And the capsule is coming down here. And that is where the main blood supply comes to the head of the femur. So it's coming through the capsule. So the fracture's not interrupting that blood supply. So the risk of this bit of the head getting avascular necrosis is going to be far less. So that, you're absolutely right, is an extracapsular fracture. The blue line connects the greater trochanter to where the lesser trochanter is. The fracture actually goes through the lesser trochanter. And you'll hear people talk about this in different ways, whether it's between the trochanters, intertrochanteric fracture, a per-trochanteric fracture through the trochanters. There is semantics, whether you call it per-trochanteric or intertrochanteric. They're very similar things. And then we think about being extracapsular. It's outside of the joint capsule. So that affects the blood supply. And that really tells us what we're going to do in terms of treatment. Now, should we do a total hip replacement or a hemiarthroplasty, a half hip replacement, or should we try and fix it?
Did we say fix it with an intramedullary nail?
Absolutely, yeah. So for the purposes of your general knowledge, fixing it is absolutely the thing that we're going to do here. How you fix it, whether it's with an intramedullary nail, that's what the IM stands for, intramedullary nail, or with some other kind of device, such as a sliding hip screw, that is a subject that we don't need to get into. My preference would be an intramedullary nail for this injury, and it's all to do with the stability of the fracture configuration. So if you imagine the different ways of fixing this, so obviously you're going to reduce any fracture before you fix it. If you had a plate on the outside that has a little barrel and then a screw which goes inside it up into the head like that, and the screw inside has only got threads at this end, and that allows for the forces to combine here where the fracture is, so that the fracture can heal as the screw pulls it down or collapses down onto the base of the trochanters here. That's the principle of sliding hip screw, and it's got 4 screws or 3 screws down here. So it's a plate with a large screw, and it's a sliding hip screw, so it goes down in the direction of that green arrow. The other way of doing it is with an intramedullary nail. So the intramedullary nail, and then it has a screw which goes up into the head. And that basically allows you to compress here and here. And that's what we want for fractures to heal. We want interfragmentary compression, 2 fragments between the fragments to compress. There are pros and cons for both. The key thing is that you get a better compression. It's then fixed at the point of surgery, and also you've got a much shorter lever arm on this screw. The force, that distance is much less than if it was to be out where a dynamic hip screw is, which would be out here. The distance here and the distance there are not the same. The distance from where the screw into the head meets either the nail or the plate, and therefore if you think about it as a lever, there's less force required to push down on the blue hip screw to cause a break here. So as somebody walks on that, less force is required to break that. I think it's safe to say, for the benefit of your overall education, that either answer is correct. And if you don't want to court controversy, just say this requires an operation to fix it. And I don't think it's worth getting more hung up on it at this stage.
Thank you for listening. We hope this has been informative. If you have any questions or suggestions for further programmes, please contact us at thegrandacademy@btinternet.com.